Morning, guys. So let me introduce myself, or good night, depending on where are you watching me from. My name is Dr. Karim. I am the head tutor at thematchguy. I have been tutoring and teaching USMLE Step 1, Step 2, and Step 3 for the past 5 years. And I have scored 279 on my Step 2 exam and passed my Step 1 exam. Now, as you may know, in this webinar, we will go through the nutrition section. And I don't know who's of you guys is fan of nutrition. Me, myself, I am not. Because when it comes to nutrition, there is always these weird biochemistry that you always ask about, or these weird things about calories, which I am not a fan of. But hopefully, by the end of this session, you will have a much, 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 much better understanding of the nutrition itself and how usually these questions will show up on the exam. Okay. I believe we have already made two webinars about nutrition so far. So this one would be a little bit different. In this one, we will answer an actual USMLE-like questions that can be similar to the ones that will show up on the exam. And we will go through how we can answer them with each other's while giving you some test-taking strategies and also some important high-yield information about each topic. Okay. Hopefully, by the end again of the webinar, you will be able to get few points here and there extra in your exam, and some of them will show up on your exam day. Okay. Let me share my screen now, and we can go ahead and start. Now, one thing that I want to add is that before we start, guys, if you haven't already, please make sure to download our high-yield PDFs. We will be leaving the link in the description below. And also try to, if you want, you can usually try one of the tutors that we have for a free 30-minute session. And if you like their style, you can commit to one of the packages. That's usually one of the things we offer, is that you can literally try them for free until you find the tutor that you vibe with. And also, you can join up our 7-day USMLE crash course. I see already that there is multiple students here that are subscribed to the crash course or our QBank, Synapse QBank. Now let me share my screen here and let's focus on it. Yes. So the questions we will go to answer here are usually for step 1 and step 2, but these ones are more step 2 focused. I still believe step 1 students will find it helpful a lot, but it's more of step 2 focused questions. But you will see lots of patient chart and long vignettes, and we will try to learn how we usually can approach these questions with each others. Okay, I usually want you to be able to answer these questions if you can, but I do not care if you answer it correctly or incorrectly, guys. I just want you to answer it so the session can be more interactive. And if you have any questions, just write on the chat. Okay, now let's start. Of course, as you know, Jovaria, step 2 is literally the same as step 3 when it comes to the QBank. The only difference is that the step 3 has an additional CCS cases and they focus more on the pharmacology and the microbiology. So of course, when it comes to this webinar itself, it's the same for step 2 students, for step 3 also. Okay, now let's start here. So the first question, and maybe I can zoom in with you. 1 second. Okay, probably that would be better so you can read everything with me. Okay. So the first question is that we have a 68-year-old man. He is coming to the office due to 3 months history of progressive unsteadiness, forgetfulness, and irritability. Now, as you can see, I have made the first mistake, which is that I'm just reading without a specific purpose. And that's what usually lots of students do. Now, to figure this out, some people will tell you, read from the last sentence. But let's try to read from the last sentence here. So which of the following best explains this patient's current finding? It gives me nothing. So when people say read from the last sentence, I don't think that's the most efficient way to go through a question, guys, especially if it's a very long question like this. What I usually prefer myself is that I read the last 2 sentences or 3 sentences and then I go through the answer choice. This gives me a much better idea of what they are trying to ask. Okay? So here, for example, what they are saying is that patellar reflexes are +3 So at least I know now they are asking about an upper motor neuron lesion because I know the normal reflexes are brass too. While Achilles reflexes are absent, I don't care about it that much because I know that when you get old, your Achilles reflex can be absent, by the way. That's something that the students usually get mixed up. When they see that the Achilles reflex are absent, they think that there is a lower motor neuron lesion, but usually this is normal in old people. Okay? And there is positive plantar reflex, so again, upper motor neuron lesion. And they're asking which of the following best explains this patient current status. And all the answered choices here are about things that can affect the nervous system. So now I have a much better idea of what I am going to face. Now I have a clue a little bit, which is the upper motor neuron lesion, and another clue, which is that they are asking about the neurology system itself. And this helps me be more structured when I read the question. Now, while I'm reading the question, I want to localize the lesion, and that's usually the most important stuff. So please, guys, when you approach these questions, try to read the answer choices and also try to read the last three sentences, not only the last one. Now let's read here. So this person is having unsteadiness, forgetfulness, and irritability since retiring from his job as an accountant 2 years ago. Okay, fine. He has spent most of his time gardening and reading. That's fine. He mentions that his sleep has been somewhat disturbed lately, and he often wakes up in the early hours of the morning and notes that he feels off balance when getting up at night. So there is two problems now. The first problem is that he has forgetfulness. And when I think about forgetfulness, I think about dementia. And dementia can be caused either by Alzheimer dementia, guys, or it can be caused by some reversible causes. And these reversible causes can be the thyroid hormone, thyroid problems, it can be B12 deficiency, and it can be depression, aka pseudo dementia. So now I have in my mind some causes here or some probable causes of this patient dementia. This person is also feeling off balance and aka ataxia, and this can happen usually by multiple reasons, but the most common reasons is that either the dorsal column of the spinal cord is affected or the cerebellum is affected. Okay, now let's continue and see. This person is occasionally needing to hold on to walls because he is having this ataxia, and his medical history is significant for type 2 diabetes, and he underwent surgery 4 years ago for localized gastric adenocarcinoma. Now, because we are in the nutrition, it makes sense that I would focus on the surgery he had. This person probably had underwent gastrectomy, so he removed his stomach, and probably the question is resolving around it. Now, whenever you see a suspicious risk factor, guys, please focus on it. That's very important. Like, for example, when I am reading type 2 diabetes, it doesn't feel suspicious at all that a person is having type 2 diabetes, right? Of course, when it comes to neurology, I know diabetes can cause peripheral neuropathy, but it's not uncommon that they just put diabetes here out of a filler without a specific purpose. But when they put something very specific, like gastric adenocarcinoma, then I know that usually the answer rely on this specific risk factors they mentioned. Okay, so now I have my risk factor that this person underwent gastrectomy. Okay, he also has been adhering to a strict low carbohydrate diet to manage his diabetes without medication, and he admits to eating sweets at family gathering. Okay, and but metformin can cause this, but this person doesn't take any medication. That's the thing, Bakar. Okay, now blood pressure is fine, pulse is fine, temperature is fine, cardiopulmonary examination is unremarkable, the abdomen is soft and non-tender with a well-healed midline surgical scar. Neurological exam shows swaying when standing with his feet together and eye closed. That's very important, guys. This is here a very important sign. When you stand with your eye closed and you sway down, do you know what is it called? This sign specifically, guys? Very good. Romberg sign. Amazing, guys. Romberg sign. Now, can I tell you something very important? When it comes to a person having ataxia, you can have ataxia by two common causes. The first cause is that your dorsal column tract in the spinal cord is affected. The second cause is that the cerebellum itself is affected. When the dorsal column is affected, we call it sensory ataxia. Now, how do I differentiate that the dorsal column is affected and the cerebellum is affected? Focus here, guys. In order to maintain the balance of the body, you need three specific organs. You need your eyes to see things. You need your ears to keep like the balance in the vestibular system. And you need the dorsal column of the spinal cord. The three of them will go to the cerebellum and they will maintain balance. And to be honest with you, two of them are enough. That's why blind people, they can still walk normally because they can hear and they have dorsal column of the spinal cord. That's why deaf people can still walk normally because they can see and they have dorsal column of the spinal cord. Okay. Now, where would the problem happen? The problem will happen if you have sensory ataxia, so your dorsal column is affected, and then I ask you to close your eyes. Now I don't have my eyes, I do not have my dorsal column, and I can only hear. Now the person would have an ataxia. And this is called the positive Romberg sign. And this usually tells me that the person is having sensory ataxia in the dorsal column of the spinal cord. They will tell you the person is fine normally, but when he closes his eye or at night when he can't see, he starts to sway right and left. This tells me it's the dorsal column itself. Because if it was the cerebellum, the person will have ataxia 24 hours continuously. Okay? So that's very important. When they say swaying when standing, that's positive Romberg, and this tells me the dorsal column is affected. Okay? Now, there is two important conditions that can affect the dorsal column, and they can also cause dementia. The first cause is tabes dorsalis. Tabes dorsalis usually just affects the dorsal column and that's it, which usually happens from tertiary syphilis. But the second cause is a disease called subacute combined degeneration. In this disease, guys, the dorsal column is affected, so you will have sensory ataxia, and also the corticospinal tract is affected. So you will have an upper motor neuron lesion, like for example, hyperreflexia, which is this person, which what this person have, and also positive Babinski sign. So this person here is probably having the subacute combined degeneration. The dorsal column is affected, and they also have corticospinal tract that's affected. And the subacute combined degeneration, guys, is usually caused by vitamin B12 deficiency, which is what probably this person is having. Now, I want to ask you a question. This person is probably having a B12 deficiency because we removed his stomach, right? We removed his stomach. So I will ask you, if you give the person vitamin B12 plus intrinsic factor, would the problem be resolved or not? So we give him B12 orally plus intrinsic factor. What do you think? No or yes? Let's talk like hypothetically, guys. So let's say I removed the stomach, but the terminal ileum is fine. Terminal ileum is fine. I haven't affected the terminal ileum. I just removed the stomach. Very good. Very good. Yes. So the problem because we removed his stomach, guys, is that he doesn't have parietal cells that secrete intrinsic factor. Okay. And that's why he cannot absorb B12 in the terminal ileum. Now, if we give him intrinsic factor with the B12, then the problem is solved. Then we can absorb the B12 and now we do not have a problem. So these people, if you give them an intrinsic factor with the vitamin B12, usually the problem would be solved. A more common cause that they ask about also similar to this is pernicious anemia. Okay, pernicious anemia. Okay, of course, Basim, that's why probably sometimes we give them like some acids, or the intrinsic factor itself is usually coated with an acid. It's usually active when we give it. Okay, but I'm just telling you this specific hypothetical scenario. So here this person is having a B12. One thing on the exam is that they will ask you about the other names of vitamins, and you need to be aware of it. So here the other name of B12 would be usually cobalamin itself. Okay, cobalamin. Very good. Okay. Amazing, guys. Amazing. Now, let's go to the second one. Okay. So again, the only thing I want you to know now is this person is having subacute combined degeneration, which is affection of the dorsal column and the corticospinal tract. and sometimes also the spinocerebellar, but this one is not that important. Okay. Now let's go into this question with each others. So, no, not this one, this one. So this is a patient chart. And if some of you do not know, guys, but right now in the recent exam, when we asked our students, they have lots of patient chart questions. And that's why we tried to make sure that we have like literally like 25% of our questions are from patient charts. So let's read here. So a person is coming to me. Again, I don't care about all of this. I go straight forward. 1 second here. I will just go straight forward into the options and I try to read the options. So the options here are non-contrast CT scan, 55% dextrose by intravenous thiamine by dextrose, intravenous thiamine and urgent magnetic resonance of the brain, and 0.45 Sully. So now I know they're asking about some kind of electrolyte replacement, and they're also asking about thiamine a lot. And this makes me think about the thiamine deficiency and what can happen in thiamine deficiency. So let's read here. This person has a strange behavior and difficulty walking. That's the first thing. They have underwent Roux-en-Y gastric bypass. So again, they removed their stomach and part of the duodenum. And also they are having non-bilious vomiting for the past 14 days. Okay. Now, he nearly falls at home and he is having class 3 obesity. You need to know, guys, like these classes of obesities, okay? We will go through them. And type 2 diabetes mellitus. He is taking multivitamins, but haven't taken them for 2 weeks. That's very important. And when we did the examination, that's what matters here. First, he is tachycardic. Second, there is lethargy. So when I read these things, I need to only highlight the specific signs. I don't care about lethargy. That's not a specific. It will not give me anything. It will just confuse me. So I will care about there is limitation of abduction of both eyes. So this person is probably having nystagmus. That's the first thing. The second thing is that he is disoriented to time and the place. So he is having some kind of confusion. Okay. And the third thing is that he is having decreased sensation to vibration and the proprioception. So he is having ataxia, right? So this person is having ophthalmoplegia, ataxia, and confusion. So what are you thinking this person is having, guys? And which structure in the brain is probably can be affected by this person? Amazing. Perfect. This person is probably an alcoholic and he is having thiamine deficiency, right, Ishwarya? And because of this, Tanya, he is probably having Wernicke encephalopathy, which you will see that the triad of ophthalmoplegia, he cannot move his eyes, ataxia, and confusion, which is what this person is having. And usually the structures that would be affected would be the mammillary bodies, which can cause something called Korsakoff. In Korsakoff, the mammillary bodies is affected. The person will have memory loss and something called confabulation, which is making up things that did not happen. Okay, so this person is having Wernicke-Korsakoff. That's very important. Now, when I look at the vitals, I already have the diagnosis in my mind. I will just look at the vitals very fast. I see that this person is also hypoglycemic, which is expected in people that are alcoholic. Usually alcoholics are usually hypoglycemic. Okay, guys? Another thing, because they have starvation, they are starving. Okay, they do not eat that much. They are malnutrition. They have malnutrition. Another thing is that there is hypokalemia and hyponatremia. We are in nutrition session, so I want you to know all the things you can ask. The first questions you can ask. What's the most common electrolyte abnormality in an alcoholic person? Hypomagnesemia. The second question, what would be the level of sodium and the potassium in alcoholic people? Low. So they will have low magnesium, that's the most common electrolyte abnormality. They will also have low sodium, low potassium, and low glucose. Okay, guys, that's very important. So now, how would you manage this? I can see already some answers from Samurai, from Najati, from Sosai, from Sarah. What do you think, guys? How we can manage this person? Is it A, B, C, D, or E? Perfect, guys. Perfect. It's very important. You cannot imagine how many questions this concept has been asked in the NBMEs of step one, on the NBMEs of step two, even on the NBMEs of step three. Okay? Whenever you have an alcoholic patient with hypoglycemia, even if they don't tell you explicitly that they have Wernicke-Korsakoff, you will still need to give thiamine first to them, and after thiamine, you need to give them dextrose. And the reason you do this is that if you give dextrose first, this will consume the thiamine that you have, and this will cause more thiamine deficiency, which will worsen their condition. And that's why you always need to give thiamine first and then dextrose. One of the other correct options is giving them at the same time. You can give them at the same time, guys. But don't give dextrose first and then thiamine. That's very important. Okay? So again, that's everything we said. This person is having Wernicke-Korsakoff because he underwent Roux-en-Y. But again, I was talking about alcoholics because it can also happen in alcoholics people. Okay. One of the things that you need to know from these high yield concepts is that this is a triad here: encephalopathy, oculomotor dysfunction, gait ataxia, and also that you give the person thiamine before or with glucose. Never give glucose alone. Okay. And the complication would be Korsakoff itself. Yes, Ibn Bashir, it's also nice to see. I see lots of people from the high yield course here. To be honest, they have always been attending with me these nutritions and these webinars in general. Okay, so that's for this question, guys. Now let's go into a hard question about pediatric nutrition, which they always love to ask about. Okay, so let's see here. A 7 months old boy is brought to the office for a routine well child visit. He was born at 39 weeks gestation via an uncomplicated spontaneous vaginal delivery and received intramuscular vitamin K shortly after birth. Again, I will skip all of this. I will read here the last sentence is that the mother asks for guidance for the infant nutrition. Okay. And I will read also that this person here is the answer choices, which are like continue breastfeeding, giving vitamin D, giving iron. So I am kind of having an idea of what they are asking. So I know now this person is young, that's pediatric, and they are asking about the person nutrition. So now I need to focus on three things when they ask about pediatric nutritions. I want to focus on the age of the patient. I want to focus if the person is exclusively breastfed or they are formula fed. I want to focus also in any red flag the person is having. So age, how he is being fed, and also any red flags. So let's read with each other's here. So he is 7 months old, okay? He was born 39 weeks and he already have been given vitamin K, which is the most important thing. Any person, you need to give them vitamin K once they are born, okay? Now, he also has been exclusively breastfed, that's important. And he receives oral vitamin D daily, which is also important, okay? The mother states that he hasn't had yet received any food other than breast milk. So he is 7 months old, but he haven't received any food. That's very important because usually you give infants food from 4 months to 6 months. Okay. The infant is meeting all developmental milestones. He can sit without support. So he is meeting all developmental milestones. I don't care about reading it in details. Okay. And his length and weight are fine. They are fine. They are fine, Sarah. I will say not optimum when they are less than 5% or sometimes third percentile. Third percentile or fifth percentile. That's usually when I say there is failure to thrive. Even if they are not synchronized with each other, it's fine. Okay. He also is very healthy, active, and have flat anterior fontanelle. That's fine. Okay. When the person has bulging anterior fontanelle, I think about increased intracranial pressure, but this is normal flat. It's also not sunken because when it's sunken, anterior fontanelle, when it's depressed, I think about dehydration. But this one is flat. It's not bulging, so no increased intracranial pressure. It's not depressed, so it's not dehydration. Then the abdomen is soft. The mother asks for guidance, and that's it. So she's asking about when to introduce solid food. Would you continue vitamin D? And should you start him on zinc or iron? So what do you think, guys? This 7 months old, What should you do about breastfeeding, about introducing vitamin D, about iron and zinc? Yeah. He is 7 months old. He is full term, 7 months old. Everything is fine on him. What do you think? Again, some of these questions you will see they are hard, okay? Because again, sometimes they are not forgiving when it comes to nutrition on step 2 and step 3. So we will try to do some hard questions here and there. Okay, perfect. Okay, so I told you that this person needs to be introduced to solid food. But does this mean that I need to change the breastfeeding frequency? No. Usually, when I introduce infants to solid food, I need to continue breastfeeding on demand, guys. That's very important. I don't need to decrease or increase it. That's the first important thing. I need to continue it on demand, meaning whenever I feel that the baby is hungry, I can give them breastfeeding. That's the first thing. The second thing is that I need to introduce solid food right now. I told you you need to introduce it by 4 to 6 months. So I will introduce solid food. The third thing is that you need to maintain vitamin D. Usually, vitamin D is very important in the whole pediatric age. So whenever you can maintain vitamin D, you will need to maintain it. Okay. And the last thing is that you don't need to add zinc or iron, guys. I'll tell you why. That's usually the confusing part. Some of you know this information that you need to start iron supplement when the person is 4 months, right? Isn't this correct, Mitten? But you need to stop it once you introduce them the solid food. That's the thing, Mitten. You don't continue it indefinitely. You start it at 4 months. Once you introduce solid food, you will stop it. Okay, Mitten? That's usually the trick in this question here. So don't just start it and continue it. Okay? So this person here can be introduced solid food, which is what are we going to do right now, Tanya? We are just going to introduce solid food. There is no purpose of adding iron now because solid food usually has lots of iron, so it will be defeating the purpose. So we'll just like introduce solid food, and we don't want to add iron supplement at all to this person here. Okay? Now, one of the questions I want to ask you guys, can you give them cow milk now? Can you give them cow milk? This person is 7 months. Can you give them cow milk? And if not, why? No. You cannot give cow milk because it can cause iron deficiency anemia. That's the main thing. That's the more common thing, Rosia. It can cause iron deficiency anemia in less than 12 months old boys. If he is less than 1 year, don't give them cow milk. Okay? So that's a few things that I want you to know, guys. Let me show you here the few things that I want you to know about the vitamin K itself and about also the iron supplements. Okay? So the first thing is that at birth, I give them vitamin K and vitamin D. Okay. And usually you can just continue vitamin D whenever you want until they are drinking an adequate amount of milk. Because milk is usually fortified with vitamin D until they can drink more than 1 liter per day of milk. Okay. Now, fortified formula or milk. The second thing is that at 4 months, I will give them iron. But if they are premature, I will give them iron at 1 month. If they are premature, I will give them iron at 1 month. The most important thing is that I do not just give them iron and that's it. I will give them iron until they reach 6 months. Once they reach 6 months, I will discontinue the iron drops and I will give them iron and zinc solid food. That's very important, guys. Okay? Then at 12 months, I can give them cow milk. But I avoid it prior to 12 months because this can cause iron deficiency anemia. So that's the few things that I want you to know about pediatric nutrition, guys, that they can ask you about on the exam itself. Okay? Now, cow milk can also cause something called cow milk protein allergy, which will cause bloody diarrhea in a normal infant that he is less than 6 months. That's also correct, Tanya. Now, let's see this question here. We will discontinue vitamin D once they can take more than 1 liter of milk, of fortified milk, not breast milk. Okay, Solomon? More than 1 liter per day of milk, then we can discontinue the vitamin D drops. Okay, Solomon? Now, let's read this question here, guys. This one is hard, but I want you to focus on one thing. This person, so let's focus here. Arthropometric measurement reveals a height of 180 and a weight of 120, and the fasting laboratory shows a serum glucose of 115 and the hemoglobin A1C of 6.1. Based on this arthropometric measurement, which of the following best describes this patient weight classification? Is it underweight, normal weight, overweight, class 1, class 2, class 3? So for this one, guys, I will usually calculate it with you. Do you know how to calculate it? How to calculate the BMI? We will use the height and the weight. But do you know how? Okay. So how did you do this, mate? Very good. We will do the height square and then we will divide the weight by it. Okay. So the height square and then we will divide the weight by it. Okay. And you will figure out that the BMI at the end, okay, would be about 37, 36, something like this. Okay, guys? 37 BMI. Now my question for you, which one here is the classification of this BMI? Do I want to teach you this? I don't. Do I have to? I have. Because now the nutrition is introduced and they can ask about these things. Very good. Very good. Guys, when the BMI is 37, from 35 to 40, that's usually class 2 obesity. So he's having class 2 obesity. Okay. My next question. Does this person need bariatric surgery? Bariatric surgery? Does he need a surgery for his obesity or not? If he have type 2 diabetes and hypertension, what does he need it or not? He has type 2 diabetes and hypertension. Does he need it or not? Very good. Here is the thing. No, it's also for step 1. Yes, guys. This person here is class 2 obesity, and usually he will need surgery. I will tell you why. Let me look at this high yield table with you here. Okay. So underweight, that's things like, for example, anorexia nervosa or anything like this. Please take care that underweight people, they still need nutrition rehabilitation, okay? And we can answer a question about them. Normal weight is usually until 25 or 24.9, and an overweight above 25. So if you are above 25 BMI, you are an overweight, you don't need anything, you just need to do lifestyle modification, okay? Now, obesity starts from BMI more than 30. Class 1 is from 30 to 35 or 34.9, and the class 2 is from 35 to 40, and the class 3 more than 40. Now, it's a very high yield to know which of them will need bariatric surgery. So if you are more than 40, you need bariatric surgery anyway. But if you are between 35 and 40, then you will need bariatric surgery if you have comorbidities. For example, if you have hypertension or diabetes or dyslipidemia or metabolic syndrome, then you will probably need bariatric surgery. That's usually a question they ask. Okay. Now, how about if you have class 1? If you have class 1, then usually you will just do lifestyle modifications and pharmacotherapy. One of the pharmacotherapies they ask about right now is GLP-1 agonists. You know Ozempic? Ozempic guys can usually help you lose weight, and they're also even good if you have like hyperglycemia or diabetes mellitus. So usually Ozempic, which are the glutides. Yes. Okay. We can use many drugs like Orlistat also. We can use stimulants, but usually Ozempic is good and it's usually well tolerated, which is GLP-1 agonist, semaglutide, guys. Okay, semaglutide. Um, that's very good. That's very good. So take care how we calculate these BMIs. So again, the weight divided by the square of the height, because they can ask about it. And take care when would we do the bariatric surgery itself. Okay. Now, let's see this question here. Okay. I am trying to also impede other systems with nutrition so I can give you high yield information about other systems. So let's see this one, for example. So they are telling me cardiac auscultation reveals tachycardia and S3. Again, whenever I see an S3, I think about either dilated cardiomyopathy or just decompensated heart failure in general from volume overload. Now, the extremities are cool to touch, so this person is having decreased cardiac output, and there is +2 bilateral pitting edema up to the knees, so this person is having volume overload and decreased cardiac output. Now, which of the following is the most likely present? And here they are describing types of heart conditions. And that's very important. I need to know which type here is the cause, so I need to figure out what's the reason of this person decompensation. Let's read and see. This person here is having 3 months history of progressive shortness of breath and lower extremity swelling. Okay. Over the past 2 weeks, he has had a sleep propped up on 3 pillows to avoid waking up gasping for air. So this person is having nocturnal dyspnea and they are having orthopnea, meaning they have to sit on multiple pillows, which is very specific for heart failure, right? Now, this person works as a freelance writer. He takes no medication, everything is fine, but they are having a bilateral parotid gland enlargement. So this person is probably vomiting a lot. But I don't think they have anorexia. I don't think a 54-year-old man would have anorexia. So I am thinking about the second most common cause of vomiting that will cause parotid gland enlargement, which is usually alcohol. This is usually solidified by telling me that the person is having a spider angioma, which is usually a sign of alcoholic or cirrhosis in general. So I know this person is probably alcoholic, guys. Okay, now let's continue and read. The jugular veins are 8 centimeter, which is jugular venous distension, and there is bibasilar crackles. So this person is alcoholic, and they are having heart failure. And the heart failure that the person is having here is affecting the left heart. That's why there is like basilar crackles and edema. And also affecting the right heart. That's why there is jugular venous distension and there is lower limb edema. And it's probably coming from S3, which can differentiate. I don't want to spoil it. I want you to try to answer it first. But usually S3 will tell me something, S4 will tell me another thing. Okay? I welcome. I will. So what do you think is the cause here? Mariam, what do you think? Michelle, Gucci, amazing. Amazing Abdi. Good Vasim, good Nazareth, team. Amazing Rashid. Amazing Madiha. Perfect, guys. Perfect, sir. Perfect, guys. So this person here is probably having dilatation of all the 4 chambers with decreased ejection fraction, which is dilated cardiomyopathy. Can I tell you something that will literally give you like 3 or 4 questions correct on the exam? If you see an S3, that's usually dilated cardiomyopathy, which happens from volume overload from eccentric hypertrophy. Okay, so S3 is dilated cardiomyopathy. And the causes of dilated cardiomyopathy are a lot. There is many causes. Okay, for example, it can happen from alcohol, which is this person. It can happen from peripartum. It can happen from whatever, Coxsackie virus. It can happen from Chagas disease. Chagas disease. It can happen from drugs like trastuzumab, like doxorubicin. So it can happen after myocardial infarction, ischemic, right, guys? Right, Abdi? So there is many causes. I don't care about remembering all of them, but I care about if you see an S4, that's a hypertrophic cardiomyopathy, which only there is 3 causes of it in the USMLE. From pressure overload. The first cause, hypertension. Amazing, Tanya. The second cause, aortic stenosis. Amazing, Susay. The third cause, HOCM. Hypertrophic obstructive cardiomyopathy. Hypertension, aortic stenosis, and HOCM. So if you see an S3, you know it's dilated, many causes. If you see an S4, it's hypertrophic, only these 3 causes. Hypertension, aortic stenosis, and HOCM. So this person here is S3, so I know it's dilated cardiomyopathy. Okay, it can be normal sometimes in pregnant people and athletes also pass them, but usually it's abnormal. Usually it's pathological, to be honest. S4 is the one that can be normal in athletes, but S3 is usually pathological. And look at the symptoms and signs. If you see symptoms and signs, you know it's abnormal. So this person here is having alcoholic dilated cardiomyopathy. Now let's go into the other choices. Let's go here, Hamad. The first thing, asymmetrical septal hypertrophy. This is HOCM. It will cause S4, right? HOCM. Very good. How about this one hard? By atrial enlargement. So enlargement of the two atria. What do you think? What can cause this with normal ventricular wall? This is a condition that can be positive for Congo red. Congo red positive guys. Congo red stain. What do you think? It will cause restrictive cardiomyopathy. Yes. Amyloidosis, guys. When amyloid deposit on the heart, it will deposit on the two atria. Okay? That's amyloidosis. Now, concentric left ventricle hypertrophy, that's hypertrophic cardiomyopathy in general from hypertension, not from HOCM or from aortic stenosis. Hypertension and aortic stenosis will cause concentric hypertrophy of the whole heart. But HOCM, which is obstructive cardiomyopathy, will only cause it of the septum, septal hypertrophy. Okay. Now, pericardial fluid accumulation. What is this? With right ventricular diastolic collapse. Tamponade, very good, which will cause the big triad, which is hypotension, distant heart sound, and jugular venous distension, right? Big triad. Now, how about right ventricle dilatation with paradoxical interventricular septal motion? Yes. When the right ventricle dilate, guys, that's a core pulmonar, right ventricular heart failure. Core pulmonar, core pulmonar, right ventricular heart failure. The last one, ventricular dilatation with increased cardiac output and decreased systemic vascular resistance. What do you think? Increased cardiac output. How would you get increased cardiac output and also heart failure at the same time? Ventricular dilatation, there is a heart failure here. That's called high cardiac output heart failure. It can be caused by many conditions. By fistulas, by anemia, by hyperthyroidism, by Paget disease, amazing guys. But the most important thing to know is that it can be caused by wet beriberi, which can happen in alcohol. It can be caused, G can also be caused by alcohol, wet beriberi. But if wet beriberi cause high cardiac output heart failure, you will usually see warm extremities. The extremities will be warm. It will not be cold extremities, cold to touch. Okay? High cardiac output heart failure will cause warm extremities because there is too much cardiac output. So there is blood going to the organs. So here it's cool. So it's not the correct answer. So here the answer is D, guys. Okay? The answer is D. Again, that's dilated cardiomyopathy, and that's what we talked about it. Again, G was the most tempting one. G is high cardiac output, which is with beriberi, but this will cause warm extremities. Okay? It can also cause something called widened pulse pressure, which is that the systole is high and the diastole is low. That's something you also see in high cardiac output heart failure. Okay, guys? So that's a few things to focus on. Again, these are the cardiac tamponade and everything here we discussed before. Okay? Very good. Very good. Now, sorry, because you asked me a question, guys, before. So why this person is having a parotid enlargement? What do you think, guys? Why the parotid gland is enlarged here? That's it. From too much vomiting, it will cause inflammation and irritation of the parotid gland. That's why it will cause parotid gland enlargement. Okay, and this can happen again from alcoholics or from people that have anorexia nervosa. Okay, Maria? Amazing, Maria. Now let's see here. Um, what do you think? Should we do like this one? Yes, I love this. Again, we tried and I was reviewing each question myself with Dr. Asad on Synapse, and we tried to contain lots of answer choices. So when you review these questions, guys, go through all the high yield answer choices here. So you kind of like know now all the concepts or all the things that can happen in the heart. The same thing here, lots of answer choices, so you go through all of them yourself. These are probably all the causes, for example, of anemia or whatever. Let's read and see. Okay, this person here. So this question is long. What should I do? I usually read the labs. And me myself, because I have done lots of questions, when I read the labs, I can spot what's abnormal right away. So I can know this person is having some kind of macrocytosis, but the hemoglobin is still normal, by the way. So the hemoglobin is normal here. So I wouldn't say macrocytic anemia. There is just macrocytosis and there is normal hemoglobin. Um, and then I read the answer choices, and the answer choices are kind of all over the place. There is answers about alcohol, about JAK2, which can cause too much hemoglobin, um, about chest echo, SSRI, naltrexone, metanephrine, which is pheochromocytoma, methylmalonic, which is B12, polysomnography, which is what is it? The one that happens to people, obstructive sleep apnea, right? Amazing. So I don't know what it is, to be honest. It can be a question about hypertension, it can be a question about anemia. Because I know, for example, obstructive sleep apnea, metanephrine can cause hypertension, alcohol also. Or it can be about anemia. I don't know. Let's read and see. Okay. A person coming for routine health maintenance, he is 48 and he is having difficulty staying asleep and the frequent episodes of burning sensation in his chest after meals. This person have GERD. He states that he has been under increased stress since separating from his wife 8 months ago and moving into his own apartment. Okay, so there is a stress. He currently takes omeprazole as needed, which provide only partial relief. He smokes 1 pack of cigarettes daily, and he drinks few beers in the evening to help wind down. Okay, so he's taking few beers in the evening to wind down. And usually when you see something like this, again, it's kind of saucy, so you need to keep it in your head. Everything is fine, but there is hypertension here, and there is also plethoric phase, and there is epigastric tenderness to deep palpation, and there is tremors when the hands are outstretched. Okay, what's the next step in evaluation? Hopefully you can read the answer choices while reading the vignette. After 20 seconds, I will zoom in the answer choices so you can read it better, guys. But the answer here are saying, is it alcohol use disorder evaluation, or would you measure the level of methylmalonic CoA? Would you do polysomnography, endoscopy, laparoscopic fundoplication, SSRI, naltrexone, ECG, or chest radiography? Very good, guys. Yes, Tanya. Amazing, Ladonna. Perfect, Dinosaurus. Basim, good. Amazing, Kara. Nice to see you, Kara. Hope you're doing well. Good, Kimberly, Z, Andrea, Rashid. Amazing, guys. Perfect. So for this one, guys, the answer would be screening the person with alcohol use. This person here is alcoholic for a couple of reasons. Can we say them? So the first thing is that alcohol will usually cause GERD. Alcohol can cause GERD, and it can happen usually after stress. Now, alcohol use, focus here, Andrea, and the alcohol withdrawal, both of them can cause tremors. You know this? Alcohol use and the alcohol withdrawal, both of them can cause tremors. Okay? Alcohol can also cause difficulty sleeping. People will use it to sleep well better, but like the more they drink, the more they have difficulty sleeping. Okay? Alcohol will cause vasodilatation, so it will cause plethoric phase, it will cause red face, flushing. And at the same time, alcohol can cause sympathetic vasoconstriction and cause hypertension. I know it's weird. It causes vasodilatation of the skin, so it will cause red face, which is usually called flushing, plethoric phase. And it also causes vasoconstriction of the arteries of the body, so it causes hypertension. And by the way, alcohol is a very common cause of hypertension, guys. So all of this tells me this person is alcoholic, right, Tanya? Also, the deep epigastric tenderness can be pancreatitis, maybe chronic pancreatitis, even if it's mild. And the last thing is that alcohol usually cause increased in the MCV. Alcohol can cause increased in the mean corpuscular volume. I don't remember the exact reason, probably because alcohol can cause fat accumulation in the red blood cells, and sometimes it can cause folic acid deficiency, depending on the cause. This cause here is not anemia. There is no anemia. So probably because alcohol cause fat accumulation on the RBCs itself. So it will make it big, okay? So all of this tells me it's alcohol. Now, how to diagnose alcohol? By alcohol questionnaire. So I will use usually the alcohol questionnaire itself. There is a questionnaire called Audit and a questionnaire called the Cage, okay? And you can use them. Tremors all happens because alcohol withdrawal can cause sympathetic activation, iPhone. But alcohol overuse can also cause sympathetic activation. It's kind of weird, but both of them can cause sympathetic activation. This tremor is not asterixis. I know that asterixis will cause the same tremors, right? When the hands are outstretched. But this person does not have asterixis here, okay? Why is there is epigastric tenderness? Because probably alcohol sometimes it can cause chronic pancreatitis. Okay, chronic pancreatitis sometimes, even if it's mild pancreatitis, mild pancreatitis. Okay, so that's a few things that I want you to take care of, guys. Okay, about alcohol itself. And the liver injury also, of course. One of the things about liver injury in alcohol is that the AST will be bigger than the ALT, right? And also the gamma glutamyl transferase will be increased, right, Najati? The gamma glutamyl transferase will be increased. Now, let's answer another patient chart question. What do you think, guys? So this is a patient chart. I go. The intern reviewing the chart states elevated ammonia after his steak dinner, confirms that the protein triggered the episode. I recommend the protein-free diet. I don't care about this because sometimes they will trick you by saying the intern. He's an intern, he doesn't know. So probably do not get confused by intern stating a thing, or by students stating a thing, or by the patient himself stating a thing. If the patient tell you, for example, I have muscle weakness, but then you examine him and it's only stiffness, then it's giant cell arthritis. Even so, I know giant cell arthritis will not cause muscle weakness, but the person is telling you, or the patient is telling you muscle weakness because they have pain, they can't move their muscles. So don't get words out of patient tongue or out of intern's tongue, is in the USMLE, of course, not in real life, okay? Now let's see here. What's the most appropriate next step in this patient management? So they're asking about hypertonic saline, lorazepam, furosemide, protein-free diet, rifaximin, hemodialysis. So I know they are asking about problem in this patient liver. Okay, so let's read and see what does this person have. I will help you going through it with each others. So this person is an old male. Let's read, guys. Guys, don't jump into conclusions. He is confused. And he's having increased confusion over the past 24 hours, and he ate large steak dinner. Okay, so I know that this person is probably having a problem here, but let's continue and see. The problem is confusion. This person has been prescribed furosemide due to worsening edema. So they have edema and confusion. And they have been constipated for the past 6 days. So they have also constipation. Okay. The past history is cirrhosis, esophageal versus ascites. So this person is having cirrhosis. So this person is having cirrhosis. So this person, when I see a person with cirrhosis and confusion, I think about hepatic encephalopathy, right? Justice. And the first thing I start looking at is lactulose. But there is no lactulose here. So I need to take my time now, because if there is no lactulose, it means that the question is hard, because lactulose is the first line, right? Let's continue and see. The medications are furosemide, spironolactone. They are taking furosemide and spironolactone. Let's continue and see, guys. And they have been already administered the lactulose right now. Today, they have been administered the lactulose. Everything is fine. He is confused, and he has the normal tremors we know. And again, can you see? We know hepatic encephalopathy people have hyponatremia and hypokalemia, right? Remember? Hyponatremia and hypokalemia. But there is something very important here. his bun is 45, his creatinine is 2.1. What does it mean, guys? Whenever I see bun and creatinine, I need to do the bun creatinine ratio. And this person is probably having bun creatinine ratio that's more than 20. So this person is probably having pre-renal acute kidney injury, guys. I don't know if it's a hepatorenal or not yet, but I know at least there is pre-renal acute kidney injury because pre-renal will cause pancreas ratio more than 20. Okay. Now, is there is a relationship between pre-renal and hepatic encephalopathy? Yes. Both of them can happen from dehydration. This person here is probably dehydrated, guys. That's why they have pre-renal azotemia and the hepatic encephalopathy. And this person is taking two diuretics. So it makes sense this person is probably having dehydration that led to kidney injury and liver injury, hepatic encephalopathy and dehydration, pre-renal injury. So can you see now? Now I know the cause of this person, hepatic encephalopathy. I don't think a stick will cause this. I think the pre-renal azotemia is the cause or the dehydration is the cause. This person is dehydrated. Remember, guys, hepatic encephalopathy can happen from dehydration, from infection, from stress, any stress. So from electrolyte abnormalities also. So what do you think here? Should we administer IV saline? More saline? Should we give lorazepam? Should we stop the furosemide? Should we increase the furosemide? Should we do strict protein-free? Should we do rifaximin? Should we do CT scan or hemodialysis? Amazing, guys. Perfect. Perfect. For this person, guys, I need to discontinue the furosemide because this person, hepatic encephalopathy, is probably caused by dehydration, and I need to stop this person loop diuretic. Okay? Can I go with you through answer choices? First, strict protein-free diet is always the wrong answer. This has always been the wrong answer because they said before that too much protein can cause ammonia. So usually they used to say prevent protein from people with cirrhosis. That's no longer correct. Usually you give them normal protein levels. So strict protein is always wrong. Okay. Administering saline will cause this person. Let's look here at the hypertonic saline. I don't think hypertonic saline would work because if you already give them saline and they are already taking diuretics, it doesn't make sense. Whenever you have to choose on the exam between stopping diuretic and giving saline, you need to stop the cause first, and then you can treat the condition later. That's the thing. And usually we give isotonic saline. We don't give hypertonic saline. Okay, so that's also wrong. Now, initiating oral rifaximin. So this is also wrong. Okay, because if the person already have taken lactulose, you don't need to initiate rifaximin right now. You usually do this if you give lactulose and lactulose does not work. So rifaximin is wrong. Okay, I am looking here for the cause of the hepatic encephalopathy, and I am trying to treat it. The cause was dehydration, and I know this cause was caused by loop diuretics. You will ask me why they give him loop diuretics at first, because he had edema at first, and we didn't know that he would be dehydrated when we gave him this. Sometimes things like this happen, guys. Okay, and that's why I should discontinue the oral furosemide. Hemodialysis. When should I do hemodialysis? There is multiple indications. I need you to know two indications. If the person is having potassium abnormalities that are causing ECG findings, that's the first thing. The second thing, if there is uremic encephalopathy. How would I know a person have uremia in general? First, uremic encephalopathy, which you see kidney failure and uremia and confusion, kidney failure and confusion, and too much bun level, too much bun and creatinine. Second, uremic pericarditis. Uremic pericarditis. Sometimes uremia can cause pericarditis. And the third cause is uremic bleeding. Sometimes uremia can cause platelets dysfunction. Platelets dysfunction. Okay. That's usually the big three: encephalopathy, pericarditis, and the platelet dysfunction. So you will see the person have BTK, for example. There is many other causes, iPhone, like yes, metabolic acidosis, like all of this, but these are the ones they ask about for the indications of hemodialysis. Okay. Now, let's go here, guys. Okay. So the answer would be discontinuing this person oral furosemide. Okay. Discontinuing this person oral furosemide. Okay. That's the thing. It's a very big topic, Basim, but to tell you here concisely, hepatorenal syndrome means that usually the liver will secrete prostaglandin. This prostaglandin will cause vasodilation of the renal blood vessels, which will cause pre-renal failure, and this pre-renal failure will lead to an end-stage renal disease. And the treatment is usually giving volume expansion. You give albumin, and also you will give the person a liver transplant, albumin and liver transplant. Okay, that's the thing. So let's read here, guys. Why not lorazepam? Because lorazepam here is a sedative. You can't give a sedative to a person who is already confusion, who is to a confused person. Okay, Bashir? That's the first thing. The second thing, why not rifaximin? Again, we can't give rifaximin if the person already is giving lactulose unless there is 48 hours that passed. Okay, so we wait for 48 hours. If there is no response, then we will add rifaximin. We don't give it right away. And the second thing, stopping the reversible cause is more important. This person here, you need to stop the offending agent. The agent that caused the person hypovolemia, the same agent, loop diuretics, that caused the hypokalemia, and the metabolic alkalosis. Okay, that's the thing. Now, let's do another question, guys. By the way, the session would be 1 hour and 30 minutes. Okay, so we can go through multiple questions with each other. Now, let's go through this question here. Okay. Now, this person, they are asking the method of nutritional support. He is 36 hours since admission and they want the method. Enteral or delaying nutrition or parenteral. Okay, I am all in. Let's see. He is 32-year-old man. He is admitted to the burn intensive care unit after sustaining 40% of total surface area burns. This person is a burn patient. Good. Not good because he is burned, but now I know what does this person have. The burn is in the chest, bilateral upper extremities, and the back. Okay, and he is intubated and mechanically ventilated. That's very important. When you see a burn patient and there is singed hair or there is carbon monoxide poisoning, you need to intubate them, right? Now, because if there is singed hair, it means that the burn can cause edema of the larynx. That's why you need to intubate these burn patients. Now, the patient requires continuous sedation with propofol and fentanyl, and he is receiving norepinephrine. Okay, so he is a little bit sedated. Over the first 24 hours, he receives 22 liters of ringer lactate. Let me tell you something. In most of the concepts, isotonic saline is similar to ringer lactate. Only in burn patients, focus here, samurai, only in burn patients, they can make you choose between ringer lactate and isotonic saline, and you will choose ringer lactate. Ringer lactate is the preferred fluid for burn patients. Why? Because isotonic saline can cause acidosis, and the burn people are usually already acidotic. They have lactic acidosis. That's why we prefer ringer lactate for them. Okay. Now, temperature is a little bit high. It makes sense. He's burning. Blood pressure is like this. Pulse is tachy. And the physical exam shows diffuse edema of the face, trunk, extremities. Because there is edema of the face, that's why I started the intubation. Now, we did ischorotomies. That's very important because if you have burn in your chest, this can cause severe edema and this can compress the lung and can cause compartment syndrome. That's why people that have large burn, we do ischorotomy to prevent compartment syndrome. Okay. Now, bowel sounds are absent. Okay. And this is the level of albumin, blah, blah, blah. And this is the calories intake. How would we give him food? What do you think, guys? How should we give him food? Okay, I can see that Dr. Ithar, Nelsa are telling me a thing. Dr. Hardik, good to see you, Dr. Hardik, from Synapse. I remember you. And Dr. Kuchi, Najati, Monica, Nazars, Hampton, Samuraizi, Justice, Sai, Dr. Nadim. Amazing, guys. Okay. I will ask you a question. Do you see parental nutrition here? I never want you to pick it until there is no other option available. Until there is no other option available. Okay. First, why wouldn't we choose oral? Because this will delay things. This person is intubated. You cannot like tell him, okay, take shawarma, take kofta, take some meat. It doesn't make sense. This person is intubated. You can't put food on his mouth. It doesn't make sense, guys. So oral nutrition support will be the wrong answer. Okay, but delaying the support is also the wrong answer. You can't delay support. Okay. Now my question for you: would you do enteral or parental? Ask yourself. Why can't we do enteral? Can we do enteral or not, guys? Why can't we, and if not, why? We can. We can. We can. Okay. So the vowel sound are absent. This can make me think about bowel obstruction, right? But the first thing is that there is no cause of this person mechanical bowel obstruction. Mechanical bowel obstruction, that's a contraindication to enteral. The second thing is that the abdomen is not distended. If there was bowel obstruction mechanically, the abdomen would have been distended, guys. Okay, so being the bowel sound is absent doesn't tell me for sure that this is like a contraindication. No, this person have non-distended abdomen and non-tender and soft. So absent bowel sound is very common after burn. It's not a contraindication. You will tell me, but this person is confused. I will tell you, fine. You don't need him to swallow. You can just do an nasogastric tube, right? So only parenteral if we can't do enteral. But in this person, I can do enteral and I can do it via the nasogastric tube. And that's it. And the food will just enter and that's fine. Okay? That's the roots here. The first root is oral feeding. Oral feeding only if he can swallow. This person cannot swallow because he's intubated. Then I will go into the second route, which is usually the nasogastric tube, which need a functional GI tract, which is what this person have. Now, if this person is having a persistent dysphagia, I can do gastrostomy tube. So I will make the food go enter the stomach from the skin. Okay. After this, I can try the peripheral, but the peripheral I try it acutely. And then I can try the central afterward. Okay. Yes, even if the patient is intubated, it's fine, Judy. Okay. It's fine to do a nasogastric tube in an intubated patient. Okay. You always see there is two tubes on X-ray. Remember, in ICU patients, don't you see two tubes sometimes? One for the nasogastric and one for the intubation itself. You always see this. It's very common on the exam. Okay. So here, this person is just like burn. He is hypermetabolic. You need to give him food right now. And the food that you will give is usually by the nasogastric tube itself. Now, here is the thing. Total parenteral nutrition. I hate it. I don't choose it unless I have no other option. First, because it can cause severe infections. Second, it can cause gallstones because your gallbladder is not moving because there is no food in the stomach. So the gallbladder does not secrete bile. So it will cause gallstones. That's why I hate total parenteral nutrition. Okay. I only do it if there is absolute contraindication to enteral feeding. If there is absolute contraindication to enteral feeding. Okay, guys? What are the contraindication? Mechanical bowel obstruction. There is literally a malignancy or a stool that's compressing the bowel. I cannot make the food enter. This person can have ileus. That's not a contraindication. That's a functional bowel obstruction. I need mechanical to say there is a contraindication. Okay. We will get the recording, Janani, of this video on the YouTube. Make sure to check our YouTube channel, The Match Guy, and to check my previous webinars also. I did a webinar on the test-taking strategies. We did webinars on hematology, renal, nutrition, and we usually do webinars every Saturday at 11 a.m. EST. Okay, good. Now let's see here. Thank you, Amy. Thank you, guys. Now let's see here, guys. I want to answer another question with you. Another questions with you. Yes, the PDF also will be shared on the link itself. Okay. And Dr. Sandra here from the support team will help you guys on it also. Now, let me pick this question. Let's go. So I see an ECG and they're asking what electrolyte abnormality or the electrolyte abnormality responsible for this patient finding can also occur as a complication of which of the following. Okay, let's see what electrolyte abnormalities this person have here. So can I tell you how to do ECGs in general, guys? There is lots of things that I want to teach, but I know there is time restraint. Can I tell you how to do an ECG? Okay. So the first thing that I do is that I look if there is B wave or not. Okay. I look if there is B wave or not. So I usually look if there is B wave or not. Okay. If there is B wave, then I know that this person here does not have like things like atrial fibrillation, things like that. This person here has just normal P wave. Okay. The second thing is that I make sure that the pulse is a little bit regular. Okay. And I look at the person pulse and I make sure this pulse is regular. This person pulse is not that regular, by the way. It's not regular. Okay. Second, I want to see if there is ST elevation or if there is ST depression. How do I do this? I usually drain an imaginary line like this before the QRS and moving forward like that. So I can make sure that there is usually no ST elevation or no ST depression. This person here does not have that much ST elevation or depression. Okay, just very small depression. I will tell you why, but no, not elevation or depression that can happen from myocardial infarction, for example. So I would usually draw an imaginary line. Okay. Second, I will look at the T wave and the U wave. Okay. This person here, guys, is having a U wave that's big U wave here. Okay. This is the U wave. The T wave is usually here. The T wave is normal. So this person is having U wave, guys, U wave. And I will show you a better image after we answer the question. Now, they are telling me the person is having tachycardia and he is coming to me with generalized weakness and muscle cramps. And he's having eating disorder. Okay, so here is the thing. This person has U wave and generalized weakness and eating disorder. Can I tell you something? Here, let's say I don't know the diagnosis. I don't know the ECG. What should I do? I should use what I have. So let's say I will remove the ECG from the equation here. This person has generalized weakness and they are asking about electrolyte abnormality. Generalized weakness can happen from either hypokalemia or hyperkalemia, potassium. Hypo or hyper, right? Now this person have eating disorder. So if they tell me eating disorder, then I think more about hypokalemia, right? Which makes sense that why this person have U wave here. Now, why would hypokalemia happen, guys? It happens from vomiting in this person. But what else can cause it? What do you think? Very good. Amazing, Mariams. Very good, Niharika. Amazing, Madiha. Glad to see you again, Madiha. Amazing, Niha. Glad to see you guys. Imelda. Good. Perfect, guys. So the answer here would be primary hyperaldosteronism or Kahn syndrome. I'll tell you why. This one is too much aldosterone. Too much aldosterone will usually cause hypernatremia and hypokalemia and alkalosis. This person here have hypokalemia. Why not the other options? Pancreatitis. What electrolyte abnormality pancreatitis will cause? What do you think? Very good. Amazing. Amazing. So let me tell you a trick. Hypercalcemia can cause pancreatitis, and the pancreatitis itself will cause hypocalcemia. So hypercalcemia will result in pancreatitis, and the pancreatitis will cause hypocalcemia by saponification, which is when the fatty acids bind to calcium, so you have hypocalcemia. Hypocalcemia will cause tetany, which is not what this person have here. Okay, it will also cause Chauvistic sign and tunnel sign. Now, carbamazepine. What would carbamazepine cause? Carbamazepine, small cell lung cancer, SSRI. What do you think? Legionella, carbamazepine, small cell lung cancer, SSRIs. Very good. They will cause SIADH, syndrome of inappropriate antidiuretic hormone, which will usually cause low sodium. And the carbamazepine is a partial seizure drug and also used to treat trigeminal neuralgia. Very good. So it will cause hyponatremia. Okay. Hyperbara will cause hypercalcemia. Hypercalcemia will cause stones, groans, psychiatric overtones, which is usually depression, constipation, and the kidney stones, right? This person does not have it. This person does not have it. Head trauma can cause either hypo or hyper, both of them. It can cause either SIADH or central diabetes insipidus, both of them. Okay, both of them. Now, how about tumor lysis? What will cause what? In tumor lysis, the cell of the tumor literally get ruptured. It will cause hyperkalemia. It will cause hyperphosphatemia, right? It will cause high uric acid and hypocalcemia. So in tumor lysis, there is hyperkalemia, too much phosphate, but the calcium will be low because the phosphate will bind to the calcium. So the calcium will be low. But this person is talking about hypokalemia, not hyperkalemia. That's why we'll choose C. Okay. Now, can we go into treatments? So, what's the treatment of hyperkalemia, guys? What's the treatment of hyperkalemia in general? The most important one. So there is three drugs we can use. We can use beta agonists, we can use insulin and glucose, we can use calcium gluconate. But what's the most important one? We can also use dialysis and IV fluid sometimes. Calcium gluconate, guys. No, calcium gluconate. If you have hyperkalemia and there is ECG's abnormalities, you have to give calcium gluconate first to protect the heart. That's very important. Okay? That's very important. How about hypocalcemia? How would you treat it, hypocalcemia? Also, calcium gluconate. So calcium gluconate is for hypocalcemia or hyperkalemia. Okay, so calcium in general. How about hypercalcemia? Hypercalcemia. It's not a first line, Bashir. Not first line. Hypercalcemia, guys. Choose one. They know that you know calcitonin, bisphosphonate, and the fluids. But if you have acute hypercalcemia, what's the first one to use? Fluids first. Fluids. Second line can be calcitonin. But fluids is the most important thing in hypercalcemia to dilute the high calcium. To dilute the high calcium. Okay? Very good. Very good. I haven't seen furosemide used that much, Tanya, to be honest with you. It's a third line or something like this. Okay? We usually use IV fluids more. Now, how about hyponatremia? What do you think? How we treat it? It depends. If the cause is SIADH, then we treat it with what? With water restriction. Water restriction. Yep. Yep. But if the cause is any other cause, I look at the symptoms. If the person have neurological symptoms, like confusion, for example, or the sodium is less than 120, what should I do? There is neurological symptoms and very low sodium, 120. Very good. Then I will give 3% saline. 3% saline, hypertonic saline. But if the sodium is more than 120, still hyponatremia, but more than 120, and the person is asymptomatic, then I will just give what? normal saline. Yes. So 3% saline, I only give it if the sodium is severely low or there is neurological symptoms, because I am very afraid to cause something called osmotic pontine demyelination, which can cause quadriplegia, locked-in syndrome, which can happen from rapid correction. That's why I only use rapid correction with 3% saline if there is low sodium, very low sodium, less than 120, or neurological symptoms. Okay, guys? That's the thing. Very good. So here, this person had hypokalemia. Look here. The person had U wave. Okay, guys. Very slight depression, right? But I wouldn't say it's a myocardial infarction level of depression. It's a very low, which can happen in hypokalemia. Okay. And the person also had U wave and no T wave at all. And no T wave at all. So that's what does this ECG shows. Okay. We can focus on the EKG in one webinar, guys. Maybe on one webinar, I can go through EKG, or one of the tutors can go through EKG, and we can go through like how to answer ECGs. There is also a video we have on YouTube channel for Dr. Mahdi on how to go through like ECGs. We have lots of webinars coming up, Tanya's, for biochemistry, for immunology, and we will do one for ECG specifically. Okay. Now, let's look here. Thank you. Thank you, guys. This one, so there is 2 or 3 questions that I want to answer with you guys. Okay. Probably this one here. This one is very important. Okay, because it will help us going through all the vitamins. Thank you, Garcia, Samurai. So let's see here. A 3-year-old boy is brought to the physician by his mother because of 3-week history of irritability, hair loss, and severe dry skin. Over the past week, he has had several episodes of morning vomiting, dry skin and vomiting, and cries when his arm and leg are touched. Of course, I read the answer choices and I know they are asking about vitamins. Okay, I know this just by looking at it. You know it's vitamins, right? Or Nikki here, for example. Acne is here. Iron, tube defect, folic acid. Now, he cries whenever his arms and legs are touched. He has bone pain. Physical exam shows alopecia, scaly skin, palpable liver in the right costal margin, and bilateral optic disc swelling. The mother recently discovered an empty bulk bottle of her daily vitamin in the patient playroom and suspected that he is being consuming them. What does the cause? And the mother was taking this vitamin. Amazing, Zainab. Perfect, Samurai. Amazing, Bassam. Good, guys. Good, amazing. You're amazing. Amazing. Hardik, Madiha, Sopida, Janani. Perfect, guys. Perfect. So this person here is probably having vitamin A toxicity. How do I know this, Karim? Oh, are you focusing on the alopecia? No, because alopecia can be caused by millions of vitamins, either deficiency or toxicity. I also do not focus that much on the skin and the hair because they can be caused by multiple vitamins. My main focus here was on the vomiting and the bilateral optic disc swelling, which is papilledema. This person is having increased intracranial pressure, and this person is probably having something called pseudotumor cerebri. Pseudotumor cerebri, which is the same as idiopathic intracranial hypertension. There is increase in the intracranial pressure, which can be caused by 4 important risk factors. The first risk factor is obesity, obese females. The second risk factor is isotretinoic acid toxicity, which is used for acne, vitamin A. The third risk factor is tetracycline. The fourth risk factor, but recent research saying it's not a cause anymore, is oral contraceptive pills. Okay, but it's not a cause anymore. Recent researchers are saying no. So 3, I need you to focus on 3: tetracycline and obesity and isotretinoic acid. So this person here is probably having vitamin A toxicity. Vitamin A toxicity. Okay, and that's why the most likely here is the management of severe acne. Take care. When we give vitamin A for acne, the oral one, isotretinoic, we need to make sure first the person is not pregnant and she is on 2 contraceptives, right? Pregnancy. And we also need to take care of this side effect. Okay. Another side effect, guys, that vitamin A toxicity can cause is usually arm and legs pain. It can cause bone pain. Have some of you guys taken vitamin A supplements? You will see that your spine can be painful. It can cause painful vertebrae and painful spine. The back will hurt a lot. It can also cause depression, right? It can also cause liver problems. It can cause increased liver enzymes and hepatomegaly. So that's a few things that vitamin A toxicity can cause. Okay. Now, do not confuse toxicity with deficiency. Vitamin A deficiency will usually be the one that can cause this night blindness, which we call it nactylopia, and it can also cause biotic spots on the eye. So deficiency need to be not confused with toxicity. This person here is having toxicity, guys. Okay. Now, let's go to the other vitamins. So enhancement of iron. Which vitamin increase iron absorption, guys? Because it's an acid. It's called ascorbic acid. Which vitamin is called like this? Ascorbic acid. Yes. Vitamin C, guys. Sometimes we take vitamin C to increase the absorption of iron itself, and sometimes zinc. Yes. Okay, iPhone. Now, how about prevention of isoniazide neuropathy? Which vitamins we give? B6 or pyridoxine, because isoniazide itself, guys, can cause B6 deficiency. Okay, very good. Prevention of neural tube defect is which vitamin, and when would we give it? Is it at the time of pregnancy or 1 month before pregnancy happens? Very good. B9 or folic acid is the one that will prevent neural tube, and you give it when 1 month before pregnancy, guys. 1 month before pregnancy, you need to give it. Okay. Now, what's the dose you give? What's the dose you give, guys? That's the only time they ask about the dose. Either 0.4 milligram if you have no risk factors, but if you have risk factors, you will give 4 milligrams. What are the risk factors? For example, what do you think? What can be a risk factor of folic acid deficiency in general or neural tube defects? Yeah. If you take anti-seizure drugs, phenytoin, valproic acid, right? Carbamazepine, anti-seizure drugs. If you have severe malnutrition, if you have previous neural tube defect, amazing Sarah. So these usually are the risk factors. Methotrexate. For methotrexate, I love to give folinic acid, to be honest, Ampika. For methotrexate, I also love to give folinic acid, which is the active form of folic acid. Okay, very good, very good. Leucovorin, exactly. Now that's for the neural tube, folic acid, 0.4 for normal people, 4 for people that have risk factors like anti-epileptic drugs. Prevention of osteoporosis. So some people get this wrong. Very good. So we give vitamin D to, if we talk about vitamins to say, we still give vitamin D to prevent osteoporosis. But vitamin D deficiency usually cause osteomalacia or rickets, which is defective mineralization. Okay. But again, we still sometimes give vitamin D to prevent osteoporosis. Okay. And I understand in osteoporosis, the calcium and the phosphorus are normal, but we still give it as a vitamin supplement. Okay. So we still give vitamin D to prevent osteoporosis, but usually vitamin D deficiency cause osteomalacia or rickets. Rickets in children, osteomalacia in adults. Amazing. Now, reversal, this one is vitamin K right away, right? Reversible of warfarin. Warfarin. If you have warfarin overdose, sometimes you can use warfarin K or vitamin K. How about treatment of hypercholesteremia? Do you know which vitamin can cause this? If we talk about vitamin society, which vitamin can increase the level of HDL? We use it to increase HDL. And this vitamin can cause flushing as a side effect. Toxicity of it can cause flushing. Niacin or B3. Niacin or B3. Vitamin B3 or niacin can be used to increase the levels of HDL. Toxicity of it can cause flushing, and it happens because niacin can increase the level of prostaglandin, and we usually treat it with aspirin. The flushing itself, we treat it with aspirin. Okay. Don't confuse again niacin toxicity with niacin deficiency, right, guys? So niacin deficiency will cause the pellagra, which is dementia, dermatitis, and diarrhea. And niacin toxicity will cause the flushing itself. Amazing, Emmy. Okay. Um, very good. Now, and the last D is the death, of course. Now, another thing that I wanted to ask you, treatment of pernicious, of course, we will give B12 plus what? Plus what? Similar to the one we talked about gastrectomy. Yes. We will usually give B12 and intrinsic factor because we need intrinsic factor because pernicious anemia is autoantibodies against the intrinsic factors. And the last one is B1, which is treatment of Wernicke. Treatment of Wernicke. Okay. It's very important, guys, when you answer questions on your QBank, is that try to ask yourself what are the other answer choices and to test yourself on them. So when I prepared for my step two and I was going through questions, I was trying to figure out what can be the answer for each answer choice. So now no, I'm not only answering one question, we literally answered the 10 questions now. And that's what I want you to do when you like study with yourself. Okay. So here that's vitamin A toxicity itself, which can cause idiopathic intracranial hypertension, or we call it pseudotumor cerebri. Don't confuse it with vitamin A deficiency. Deficiency is the one that will cause this bite to spots thing and the night blindness or noctulopia. Okay, guys? So don't confuse them with each others. One thing that I would like to add is that for acne, guys, vitamin A can be used for acne. It can also be used for measles, right? Measles. That's very good. What's the third thing that we can use it for? Amazing. Acute myeloid leukemia, the one that you can see all roads on it, all roads on it. So measles, acne, and acute myeloid leukemia. Okay. Yes, acute promyelocytic leukemia, the one that's 15-17 translocation. Okay. That you will see all roads on it. Very good. Very good. Okay. Now, my timeline, oh, you don't need to know Ibn Mashir. I initially took a full 1 year and a half to 2 years to prepare for step two. But this was because I used to teach step one while preparing for my step two. But my dedicated period was about, I believe, 3 months. Okay. Now, this question is the last question, guys. Let's see. Maybe we can answer one again, but let's see this one here. So, this person had this rash, and they are having this skin rash, and his brain is foggy, and they also have. I am looking for a third thing. Um, they didn't mention diarrhea. So they mentioned only skin rash and dermatitis and dementia, and that's it. But we still know because we just discussed it, this is vitamin D3 deficiency. Sorry, vitamin B3 deficiency or niacin deficiency, balagram. It will cause dermatitis and dementia and diarrhea sometimes. Okay, and the dementia will be in the sun exposed area. It's very specific. Now, what's the most likely responsible? Which diet? Again, it's nutrition. They will ask about the diets, guys. Which diet is responsible? Is it tea toast? Niha? Because sometimes tea can have the toast can have corn on it. It's usually this one, corn, no corn, because niacin usually is found in the corn, guys. Okay, niacin is usually found in the corn. Let's go through the other one. We can go through the other ones with each others. Okay, so which one can usually cause B12 deficiency, but after few years, after 5 years, for example, you can have B12 deficiency. Which one? E, yes. A diet excluding all animal products, strict vegans. But after few years, because vitamin D can usually, sorry, vitamin B12 can usually be stored for few years. Okay. Which one would be vitamin C deficiency? Very good back. Amazing samurai. Perfect Madiha. Amazing Najim. Perfect. So it would be F. diet excluding all fresh fruits and vegetables. That's the tea and toast diet. Yes, and that's usually scurvy, which is vitamin C deficiency. Okay, vitamin C deficiency. Very good. The others are not as high yield or as important. Um, so we can go through the others, but I don't think the others are as important. Okay. For the diet that's high in cereals and legumes, this can usually cause zinc deficiency. And the zinc, guys, some of you asked me, how do we diagnose zinc? No taste, no smell, and rash around the orifices. So rash around the mouth and rash around the anal canal and the vagina or the penis. Okay, so orificial rash, taste and taste and smell deficiencies, and rash also around the all the orifices in general. Okay, so rash around the orifices and taste and smell sensation. Okay, let's see this one. This one is very important. Which diet will cause the greatest reduction in blood pressure? What do you think, guys? Which diet will cause the greatest reduction in blood pressure, and what do we call it? So they will not say dash diet on the exam. They will ask you to describe it. That's very important. Which one is the dash diet? Now they want to know. And they will not say Mediterranean. They will ask you to describe it. And some of you get it confused. Mediterranean with dash. I don't want you. So you guys are also smart because you already, I can see you are aware of Mediterranean. You are aware of the dash diet. But you don't need to get them confused on the exam. So I will tell you what's the difference between them. Okay. Okay. This one, guys. That's the dash. Can I tell you something? The dash diet has fruits, vegetables, and no fat. Low fat dairy. And this one is important for hypertension. That's the dash. The Mediterranean diet is this one, the oils and the fish and the nuts. That's the Mediterranean diet. And this one is important for cardiovascular complications. Can you memorize this, guys? Because it's very important. If we talk about cardiovascular complications, then we use the Mediterranean one because it has lots of fat. So it has omega-3, which is important for the heart. But if we talk about hypertension or high blood pressure, then we talk about the DASH diet, which usually have fruit and vegetables, which do not have lots of sodium, which will decrease the blood pressure. That's very important. So hypertension, DASH, Mediterranean, cardiovascular. Okay? Don't confuse them together. Good, good, good. Again, they will always tell you about the person circumstances iPhone. If they tell you the circumstances is hypertension, choose the dash. If they tell you the circumstances is cardiovascular, choose the Mediterranean, myocardial infarction, for example. They will not make you choose unless they give you the specific target of the person. Okay, that's the thing. Okay, so here, choice B, which is the Mediterranean itself, guys, okay, will be important for the cardiovascular complications. Okay, now some of you tell me, but Karim, why don't we decrease the sodium? Isn't the sodium is a major thing to increase the blood pressure? For your surprise, not that much. DASH diet decrease the blood pressure more than restricting the sodium, guys. Restricting the sodium will decrease the blood pressure by 2 or 6, 2 to 8, sorry. But the DASH diet will decrease it by 8 to 14. Okay, so it's very important to know that DASH diet is more important than restricting the sodium. Okay, that's very important. Okay, very, very good, guys. Very good. Here, this person has, let's answer this. I will tell you the cause. This person is having hypertension from alcohol. What's the reason that alcohol can cause high blood pressure? We discussed it before, if you remember. We said alcohol will cause high blood pressure and will also cause flushing. High blood pressure from vasoconstriction, flushing from vasodilation, right? And the reason it causes high blood pressure from vasoconstriction is because it activates the sympathetic. Remember when you asked me why it caused tremors also? Why it caused tremors? It increases sympathetic discharge. Okay, guys? It increases sympathetic discharge. Very good. Now, let's go into a hard question. Okay. Um, Here, where it is. So if I tell you, oh, this question is important. They are telling you this person has high blood pressure, guys. This person is having elevated blood pressure. Okay. And take care that he has normal BMI, 24. Okay. And his diet is bad. It's it's messed up. High in processed and restaurant foods. Which intervention will result in the greatest decrease in this patient blood pressure? Is it exercise or sodium restriction or dash or alcohol or smoking or weight loss? Take care because this question is very high yield. What do you think? Literally all of them will decrease the blood pressure, but they always ask about the greatest reduction. Amazing, guys. Guys, can I tell you something? The greatest reduction for decreasing blood pressure is usually weight loss, but only if the person is obese or overweight. This person has normal BMI. Why would you make him lose weight? So if I get to you and I tell you I need to lose weight to decrease blood pressure, I have normal BMI. It does not make sense. So I would choose weight loss if the person was overweight or having obesity. Second to weight loss is not a smoking cessation, not smoking cessation. It's the dash that we talked about. Okay, the dash we talked about. Look here, guys. Weight loss will it's literally the highest reduction in blood pressure. You don't need to remember the numbers. Dash diet is the second high. After dash diet, sodium restriction 2 to 8 as we said, and also exercise equally. So please remember this: weight loss, then dash diet. But weight loss is only correct if the person have a high BMI, guys. This person BMI was normal. So weight loss would be the wrong answer here. Okay, so weight loss is the most effective lifestyle, but only for overweight or obese people. Okay, for overweight or obese people. That's the thing. Exactly, Hala. So the greatest factor is weight loss. If the person is not obese or not overweight also, then it would be usually the dash diet itself. Okay, the dash diet itself. Okay. What else that I wanted to say? Probably that's it. Okay. So I hope this lecture was enjoyable for you guys. I know you usually do not enjoy the nutrition itself. Okay. Again, thank you so much for tuning out. Much love to you guys. If you like the style, you can again try me or any of our amazing tutors for a free 30-minute session. And please make sure to check our Synapse QBank. I made sure to review each question myself with Dr. Asad to contain the high yield important informations. Really appreciate you tuning up for me. And I can see I already know 80% of you from the previous webinars. So I literally hope that I see you again and again. And the video will be uploaded on YouTube within the next days. Okay, it will be uploaded on YouTube, guys. Thank you. Let me know on the comments also which webinars you want us to teach second, and we will just try to do it. Okay. Thank you so much, guys. One of the things that I want to say is that if I can teach for 5 hours, I would, but I know you would get bored, okay? So that's why I was rushing some questions. So thank you so much, guys, and I'll see you soon. I'll see you soon in the next webinar. Bye bye.